Welcome to the LDN Radio Show, brought to you by the LDN Research Trust. I'm your host, Linda Elseygood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. Today's sponsor is Dr. Cory Tichauer, who has 15 years of experience and success in treating tick-borne diseases and chronic infections-related illnesses. Bear Creek Naturopathic Clinic uses an integrative approach to recovery, combining modern pharmaceutical therapy with evidence-based functional medical treatments to create a clear path towards healing. Visit the website bearcreekclinic.com or phone 541-770-5563. Today my guest is Dr. Cory Tichauer. Thank you for joining us, Cory.
Thank you. It's nice to be here.
Well, we're very excited to speak to you, and you're from Oregon, and of course that's where we're going to be in a few weeks' time for the LDN 2017 conference. So first of all, before we start, I'd like to find out who you are, what makes you tick, what qualifications you've got, what training you've got. I mean, going right back, did you always know as a child you wanted to be in the medical profession?
Yeah, I did. I'd always strove to be a physician since I would say about 6 or 7 years of age. I had a parent who was involved in medical sales. I spent quite a lot of time in hospital waiting rooms and actually got to know a lot of the nursing staff. They were gracious enough to show me around many of the facilities in the hospitals, and I think that really left an impression on me as to what I wanted to do with my future and the suffering that I witnessed in those facilities and a genuine desire to try and ameliorate that for people.
Well, that's a good start, isn't it? So where did you train?
So I did my undergraduate studies at Cornell University. I was a neurobiology major there. During my junior year, my spring semester, my junior year, I spent some time studying abroad in Nepal, actually, where I was privileged enough to do a research study on traditional healing. That experience really affected me when I crunched the numbers on what they were doing there. Albeit a small study, it was surprising to show that the efficacy they were getting was about 70%, which in many cases rivals what we see in westernized countries. That experience really made me think what it means to try and heal people, what it means to be a physician, and what really my goals were for trying to form a career in medicine. With that in mind, I did a lot of soul searching and decided that it was most appropriate for me to enter into a naturopathic medical school as opposed to an allopathic school, with the belief that I would, in fact, get more of what I was looking for and find ways to integrate Western and alternative or complementary medicine, as well as try and individualize people. For that reason, I started at the National College of Naturopathic Medicine, now the National University of Natural Medicine in Portland, Oregon, in 1998. I graduated in 2003 and began my practice in March of 2004 in Medford, Oregon.
Mm-hmm. So in your practice, I mean, how far down the line was it when you first heard about LDN?
You know, actually, Linda, it wasn't too far down the line. One of the things that I wanted to do was work with the population of patients that were abandoned and hope had been given up for them in many ways. The functional cases where people were just having symptoms managed. And that really rapidly led me into the world of neurodegenerative conditions, things like MS and Parkinson's disease and RSD. And a lot of neuropathies and vague neurologic symptoms. When I started looking at those and getting these autoimmune cases as well, the goal was to say why is this autoimmune reaction occurring and what's perpetuating it. And the most surface level, it was obvious that the immune system was part of the problem, and that many of these people had overactive or unbalanced immune systems. In an attempt to look into the literature and understand what would help to shift that in the right direction to reduce neuroinflammation and help reduce progression of the illness, naltrexone came up for me. I guess back in 2004, there was probably a lot less literature on it, but it had still been established. And I looked at the literature, and without any, I would say, mentor to guide me in that way, I started using naltrexone as recommended at low doses, and was very pleased with the results that I was finding and the improvements that people were showing.
Mm-hmm. And primarily, what conditions were you using it for initially?
I'm sorry, could you repeat that, Linda?
Yes. Initially, when you first started prescribing it, what were the main conditions you were prescribing it for?
Yeah, so initially I would say there were autoimmune conditions, so lupus came up, scleroderma, mixed connective tissue disorders, as well as some of the chronic pain syndromes that we'd see. People who were actually being medicated oftentimes with opiate medications. So I believe I had a reflex sympathetic dystrophy case. We were seeing quite a lot of Parkinson's disease and a few MS cases in there. People were being prescribed gabapentin, sometimes opiates, and those are really the people I started working with. We'd get them off of those opiate medications so they would be qualified candidates for naltrexone, and with the auspice that this is an intervention that could not only ameliorate the pain by increasing endorphin levels in folks, but also help to reduce the sources of inflammation. And that was something very appealing to most of the patients that I discussed with. And when I showed them the literature, they were encouraged to either titrate off of those medications or start on naltrexone as rapidly as possible. I do remember early on, even with a lupus case that I had in a 31-year-old female with a malar rash and the rash along her arms, not doing a whole lot. Someone who did not have very much income, and I only had the choice of using maybe one or two items with her. Naltrexone was one that I tried, and I was very pleased to see that when she returned for her first appointment, that rash had dissipated so significantly as to even surprise her allopathic physicians in this case. And that was really something that impressed me with the medication and really made me aware that it's something I need to use in my set of tools with many of the folks that I work with.
Mm-hmm. And I'm sure there are many listeners who are thinking about trying LDN who may already be on opiates, and you were saying about titrating the opiates down. Could you just explain what you do with a patient who is taking opiates, how you actually wean them off?
Yeah, so it's a complicated discussion. I used to do more pain management than I do currently, and of course, it's going to depend on what opiate medications they're on, whether you're going to need to downgrade it from an oxycodone to a hydrocodone, whether you're going to need to use a benzodiazepine to help make that transition happen or make them more comfortable. But it's a progressive reduction. We will take a look at their total amount in a day and begin to slowly shave down those values. Often we'll support them with natural medicines as well, things that can help reduce pain, things like kava, for example, which can be useful. There's a variety of anti-inflammatory herbal therapies, all things that tend to be very helpful in reducing those medications. But we'll just sort of progressively do it over time and ensure that there's no side effects. In many cases, if people are using heavy doses, I'm going to be working with their pain doctor to bring them down. Quite commonly, we'll use things like gabapentin as bridges to reduce pain as well. And another therapy we've been very successful in using that I've used for about maybe a little over a decade is neural therapy, which is, I guess, in this country more or less termed regional anesthesia, but it's the use of localized intradermal injections of procaine to slow a visceral cutaneous reflex. So they're not getting the pain signals happening as much. It's more of a German therapy, but it works extraordinarily well in many cases. So I guess the answer is we have to individualize each person. But usually we're going to have them coming off of opiate medications, and I'm going to want them to be off of them for a good 10 to 14 days, typically, before we're going to start talking about adding the LDN in.
Mm-hmm. Oh, that's really good. I mean, I have known two people in the last 14 years who have decided to ignore all the advice of doctors and to stop taking stop taking the opiates that they were on, start taking LDN, and say to their doctor, "No, I'm not taking any opiate painkillers," and have ended up in ICU because they've had terrible withdrawal symptoms. So if anybody is listening, it is advisable to reduce your pain medication with the assistance of your own doctor. I wouldn't recommend that anybody tries to do that on their own. I think they need support.
I would agree with that completely.
I mean, it just isn't worth putting yourself through all of that. Definitely not.
No, and coming off of it too rapidly or starting naltrexone while people still have opiates in their system can actually exaggerate that withdrawal symptom by binding to those mu and kappa receptors, which are already downregulated from the use of opiates. So it can really, like you said, put people in a troubling situation that quite commonly will land them in intensive care.
So from the patients that you've prescribed LDN for, since 2004, I believe you said, how many patients do you think you've had on LDN?
That's a good question. So I would say, in particular, over the last 10 years, when my practice is really focused into the realm of chronic infectious illness and Lyme and neurodegenerative conditions, and I'm getting a lot more referrals from surrounding physicians based on my knowledge base, I'd say that we probably use LDN in maybe about 40% of the cases, 30 to 40% of the cases we see. Mainly because and this is something I will talk about a little bit more, but many of these cases of chronic infectious illness, infection-induced autoimmune conditions, neurodegeneration are conditions where the immune system is already out of balance. We often talk about these in these sort of binary ways between a Th1 and a Th2 immunity. While it's not quite that simple, there's often an exaggerated component. I commonly see this humoral immune reaction where people overproduce antibodies, and they're more or less flagging things without actually effectively eliminating pathogens, quite commonly seeing immune cross-reactions to their own bodies, and just continually driving this inflammatory response. LDN is a therapy that I use quite commonly because in these infectious conditions, it's not just about the damage that the bug, the virus, the bacteria is doing to a person's system. It's just as much about the inflammation that's being generated by their own bodies that's often driving the pain and the degeneration. And so to try and only treat one side, while it does produce results, it's not a complete therapy, and it's not going to result in the long-term resolution of what they're dealing with. So I sort of always am trying to look in people and say, how do I both address the cause of this problem as well as help to resolve this sort of ongoing fire that's in their bodies? And so for that reason, like I said, we're using LDN quite commonly. I tend to see about 5, 6 patients a day. I mostly do hour-long appointments, and I'm typically booked out for some months. So I guess we could do the numbers on that and say about 100 people a month, and if there's about 30% of that, I'd say 30 people times 12 times 10 years. So I've used naltrexone quite a lot.
Yes. And from all those patients that you've treated, have any of them reported any adverse side effects other than the normal sleep disturbance, vivid dreams, that kind of thing?
Yeah, not too commonly. I'd say that I could probably count the number of adverse side effects on one hand. And when I say adverse side effects, they're not objective side effects like cardiac arrhythmias or, respiratory distress or signs of actual toxicity that you might see with other medications. It's more of a subjective experience. I had one woman, I believe, who reported feeling dizzy all the time. And we ended up not abandoning naltrexone. We ended up doing what I would call very low dose naltrexone, where we're using doses under 1 milligram. And that actually worked out okay for her when we eventually were able to bring it down to a certain point. Let's see, I've had a few other cases. Mostly cognitively, I'd say the other folks are going to typically say they feel too foggy-headed, but they're often symptoms that are either associated with, instituting the medication potentially prematurely. Maybe there's something else going on that we need to address, or by starting at doses that may be too high for that individual. So if I was to say start it at a dose as high as 3 milligrams, that can be too high, and we will need to say, look, we're going to have to reduce that by half for a month or two, and then increase it slowly. But no, it's an extraordinarily well-tolerated medication, and as I mentioned, I've never seen an objective reaction, so it's something I feel very comfortable and safe in using, especially given the literature and the available information on the benefits of it.
Mm-hmm. And you were talking about prescribing LDN for Lyme disease. Now, I know that you have done a presentation for us for the LDN conference, which is available to listen to online. How do you go about establishing how to treat a patient with Lyme disease? It seems very complex, put it that way. I would be concerned if I had Lyme disease, where to start. So if somebody comes to see you and they suspect they have Lyme disease, how do you initiate their treatment?
Yeah, well, the first thing is to try and have a very thorough assessment of that individual. Our initial appointments are typically 90 minutes. Sometimes they'll run a little bit longer. But the goal is to try and understand what each person individually is presenting with. So there's a variety of things that I'll look at with each person. And, obviously finances are always a part of this if we're running a lot of lab work. And I will admit I do like labs. I do think they help to guide the subjective observations that we're seeing. But we're going to try and determine what types of infections they're dealing with. So we'll take a thorough history, get some idea of what their symptoms are, and based on those symptoms, we'll try and cross-correlate those to infections that will often cause that. So we'll do testing for viruses, bacteria, and protozoal or parasitic infections. We're also typically going to look and see whether there's exposures that may have triggered an immune depression and allowed the Lyme to flourish. So not uncommonly, there's some toxic event that could have been emotional, like a death in the family. It could have been something physical, like a mold exposure, which living in the Pacific Northwest is not unusual, or something like heavy metals. I'm typically going to try and understand what their immune system is doing. So we'll often do a workup to look at, their total immunoglobulins, whether those are high or low. We'll look at natural killer cells, whether they're active, whether they have enough of them, what the populations of the CD3, the CD19, the CD4 cells are, and sometimes actually run these Th1, Th2 panels to try and better understand things based on interleukin numbers. And as I mentioned, it's fairly common for us to see, for example, low or low normal levels of total IgG. We often see low CD19s, low CD3s, and in Lyme and these chronic infectious illnesses, quite frequently low CD57 levels, reflecting that there is an aggressive intracellular infection, and quite commonly that Th1 component of their immune system is compromised. So we're going to always look at that as well as we try and individualize each person. We're always going to look at genetics. So the field of epigenetics is obviously booming right now. The ability for us to look at each patient individually and try and understand how under specific stressors their bodies may or may not be coping with the detox processes, with medications that may be used, with their circulatory perfusion. The list goes on and on. So simple things like 23andMe and a good interpretation can help us to guide and individualize people in targeted nutraceutical therapy to offset some of those epigenetic manifestations. And then biofilms, which is something that anyone who's treated chronic infections knows well, is pretty critical to try and understand. There are some labs where you can actually get fluoroscopy views of what these biofilms look like, but we're going to want to make sure that those are addressed along with hypercoagulability and, as I mentioned, impaired capillary perfusion into extremities, joints, neurologic spaces. So that's kind of a big overview.
Mm-hmm. Yes, certainly is. So what therapies do you use alongside of LDN?
Yeah, so as I mentioned before, I do really believe in an integrative approach. I tend to think that both Western and complementary medicine have a lot to offer. For that reason, I will use pharmaceutical medications. I am an ILADS practitioner and have been since 2009, and there's quite a lot of evidence based on the use of antibiotics, not uncommonly long-term antibiotics. I will use antibiotics. We'll use, again, traditional Western medications, things like Plaquenil, hydrocortisone, naltrexone, whatever else is needed, alongside the natural therapies. So we're typically going to be using herbal therapies, targeted antimicrobials for, the variety of infections we're dealing with, biofilm therapies ranging from Google to lumbrokinase to serrapeptase to stevia to whatever is needed. Treatments to help shift the immune system to complement the LDN. I think that, for example, the mushrooms, the things that are high in the 1,3-beta-glucans, reishi, maitake, are all very helpful in assisting in that immune shift. We're often wanting to support both mitochondrial function as well as an elevated stress response. So the sort of cliche and common use of adrenal support and mitochondrial-based therapies. And then, as I've mentioned, and as you've seen, Linda, inflammation is just rampant in most of these conditions. And so whether we need to use something stronger like meloxicam or a little bit of hydrocortisone, or whether we can go with something more natural, we're going to be working on reducing the inflammation. Curcumin, liposomal curcumin's been great, boswellia. There's a lot of herbs that do that. So, the list kind of goes on. That's a bit of it.
Well, as you were saying, everybody's treatment is individualized, especially tailored for them. But if you had to say, as a rule of thumb, with your treatments for a patient, how long would you expect it to be before you noticed an improvement?
Yeah, it's a good question. I tend to do follow-ups depending on the individual, 4 to 8 week follow-ups. I would like to see a shift with that first appointment. It doesn't mean that we're going to see resolution of symptoms. And as you hear, my case presentation, which actually takes place over a year, it's a progression. So my expectation is that when I see someone after starting them and after initiating therapy, while they may initially get an increase in an inflammatory reaction or a die-off response known as a Herxheimer reaction, and they're well versed and counseled in what to do for that, I do want to have them come back and tell me that they're having less pain, that the intensity or the severity or the duration of those pain events is better, that they're having less of these neurologic episodes, whether that be neuralgias with shooting pains or stabbing experiences or crawling experiences or any of those things, that there's some reduction and some improvement in that. If we're not seeing that, then it's typically, I've missed something. So I'm usually going to go back and try and reassess and determine why that is. Of course, anytime we're using a lot of antibiotics or other Western medications, side effects are something we're always going to have to be aware of and trying to assess whether that's part of the problem. And frankly, for that reason, I anymore try not to use antibiotics more than 2 to 6 months at the most, and almost have adopted a quasi-European approach into how we deal with Lyme after that, with more natural IV therapies, high-dose vitamin C, ozone, other treatments herbally that tend to help produce that resolution without the toxic effects that we see with pharmaceutical medications.
Mm-hmm. Well, I'm going to have to stop you there. Our time is up. It's been absolutely amazing. We've learned so much from you. And and as the advert says, it's bearcreekclinic.com. All your information is on there. You did say you have a waiting list, so I recommend that people contact you and find out what that is. And thank you very much for being with us.
Thank you very much, Linda. It's been a pleasure.
Today's sponsor is Dr. Cory Tichauer, who has 15 years of experience and success in treating tick-borne diseases and chronic infections-related illnesses. Bear Creek Naturopathic Clinic uses an integrative approach to recovery, combining modern pharmaceutical therapy with evidence-based functional medical treatments to create a clear path towards healing. Visit the website bearcreekclinic.com or phone 541 770 5563. Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.